pneumonia. Signs and symptoms.
So this can also be airborne, right? Airborne transmission, like coughing.
So that's how pathogens are usually shared. Respiratory pathogens are usually shared, but when you cough, you are not coughing up things from your alveoli. You are coughing up things that are like in the back of your throat or in your upper airways, right? So I'm not really going to cough up pneumonia and transmit it to you. We breathe in like bacteria all the time, and it might get trapped in our throats, so forth and so on, but that doesn't cause pneumonia. Something else has to happen for it to get lower down. So you're usually getting pneumonia from a bug that came somewhere above in your upper airways. Okay. So upper respiratory infections are easily transmitted between people, but lower respiratory infections are usually just like you're self-inoculating. Okay, makes sense?
Mm-hmm.
So, here are some common signs and symptoms. Lots of respiratory specific things. Like we've been talking about cough, but chest pain, shortness of breath, crackles, all of those are respiratory exam based findings. Leukocytosis, an elevated white blood cell count. If you're not oxygenating well, you're going to have a lower oxygen saturation. So your pulse ox will be, might be lower. And most of the time, pneumonia is diagnosed using some kind of imaging where an infiltrate or like a bundle of kind of like a purulent bundle or inflammation is actually seen in the lungs through some kind of radiological testing. Okay, so again, it's really important to make sure you have these definitions down. So CAP, so community acquired pneumonia. These are mostly going to be caused by things that routinely kind of circulate in the environment. And respiratory viruses are super common, and then there's some bacteria that are more likely. So you'll want to focus on the orange ones here because these are the most common. Now, we don't treat community-acquired pneumonia that's caused by viruses. We really focus on CAP that's caused by the bacteria. Okay, so the guidelines really tell you, sort of, assist you in selecting therapy for empiric pneumonia. So this is when you don't know exactly what bug a patient is infected with. The guidelines have antibiotics that cover all of these. Since we don't know what it is, the empiric treatments are going to cover all of these. So it's a combination of gram-positive bacteria like Streptococcus pneumoniae and Staph aureus, as well as some gram-negative bacteria like Haemophilus influenza and Moraxella. And then there's some atypical bacteria like Mycoplasma pneumoniae, Chlamydia pneumonia, and Legionella. Okay, so it's a combination of gram-positives, gram-negatives, and atypical bacteria that are most associated with causing community-acquired pneumonia. And most of the time in patients who have community-acquired pneumonia, we don't even we don't wait for cultures or anything like that. Usually they're just treated empirically for the whole course of treatment. The only time they routinely get cultured is if they're so sick that they wind up in the hospital. So after a patient is kind of defined as having CAP or HAP, the next thing that needs to happen is they need to be assessed for severity. So this is, same kind of process for almost all the disease states, is that severity is what's going to determine and help us to use the treatment algorithms so that we can use the guidelines. And for CAP, what we're really trying to decide is, can they be treated as outpatients? Do they need to be admitted to the hospital? And if they do need to be admitted to the hospital, are they stable enough to be on the floor, or are they sick enough to require an ICU? So those are sort of the 3 levels of severity. And each of them have different treatments that are affiliated with them. There are different ways. We talked about a few different ways or tools that can help to determine treatment severity. So what were some of those tools?
That is going to have determine treatment severity.
Say that again.
I didn't hear your question.
What are the tools that we can use to determine where a patient gets treated, whether it's outpatient, inpatient, or ICU?
PSI
Mhm.
and COBS 65.
Yeah, good. So so we kind of talked about 3, and Fola just mentioned 2 of them. So the PSI, or the Pneumonia Severity Index, is here. It's a little bit more complicated. The CURB 65 is a little bit of an easier tool because there's only 5 variables and they're pretty easy to measure. And then the IDSA, which is the Infectious Disease Society of America, the main thing that they really distinguish is just who needs an ICU. So that can be applied to, if a patient needs to be admitted, they are considered to be severe if they meet any of the major criteria or at least 3 of the minor criteria. So these are all things that indicate a patient is super sick. Okay, so good. So again, usually the higher the score, the sicker they are, and they will need higher levels of care if they are sicker. Okay, so then in terms of treatment for outpatients, there are 2 pathways of treatment. Outpatients who are otherwise healthy, they can kind of get a simplified regimen that includes either amoxicillin, doxycycline, or sometimes azithromycin. But these are going to be uncommon because there's not a lot of patients who are going to get pneumonia that don't have a comorbidity or a chronic condition. Patients who have comorbidities, meaning any of these, so heart disease, lung disease, liver disease, kidney disease, diabetes, and then some, cancers, any of those patients are going to require this treatment. So it is basically either an oral beta-lactam. So the drugs that the guidelines specifically promote are Augmentin. So amoxicillin clavulanate is Augmentin. Cefpodoxime, which is a third generation cephalosporin. The beta-lactam is paired with either azithromycin or doxycycline. Remember that if you use a beta-lactam, beta-lactams never cover atypical bacteria. There are no beta-lactams that cover atypical bacteria, but we know that a lot of atypical bacteria cause community-acquired pneumonia. So we have to add on one of these drugs, either a macrolide or a tetracycline, because they do treat atypical bacteria. Okay, the beta-lactams will cover everything else, the staph, the streps, the Haemophilus, but they won't cover the Legionellas, the mycoplasmas, and so that's why it needs to be partnered with one of these medicines. Okay, so these go together. The other treatment option that it can be considered is to use a respiratory fluoroquinolone by itself. Remember that the two respiratory fluoroquinolones are levofloxacin and moxifloxacin. So you can give one drug. So you can give levofloxacin or moxifloxacin by itself. It doesn't need anything else because it covers all of the bugs that were on that earlier slide. But if you also remember, fluoroquinolones have a lot of side effects and have a lot of warnings. And so generally they're not preferred over this combination. Inez, did you have your hand raised earlier?
Yes, but you can't really answer it. I just want to add why. Do both of them have the same active ingredient that has to do with beta-lactam?
Well, they're all different beta-lactams. I'm not sure what you mean.
Never mind. I will put it like
they all have the same coverage they all have the same important coverage for CAP. All right, so that's outpatient treatment. Okay. And then inpatient treatment. So again, what were the two levels of care for inpatient treatment?
Do the PSI indicate?
So those are the tools to determine the level of care, but what are the two levels of care? If the patient is hospitalized, they either go here or here. So where is that?
Is it floor or ICU admission?
Yes. So floor or ICU. Okay. So each of those have different tables or treatments. So this is the treatment algorithm for non-severe, meaning the floor patients. Okay, the more stable patients. The standard regimen is once again a beta-lactam plus either azithromycin or doxycycline. So this is very similar to the outpatient regimen. Same with the respiratory fluoroquinolone. The difference is here is that these beta-lactams are IV. Okay, so they will work a little bit quicker. Okay, have a little bit, better systemic bioavailability. But then you also have to, when a patient is hospitalized, in general, it still means they're sicker, right? So you have to evaluate if they are at risk for MRSA or if they are at risk for Pseudomonas. So it's not common for MRSA or Pseudomonas to cause CAP, but it can happen. So if they have a history of having a MRSA pneumonia or a Pseudomonas pneumonia, then you should also you should cover for those multi-drug resistant pathogens. So if for MRSA, you would add vancomycin or linezolid. And for Pseudomonas, you would use a beta-lactam that covers or treats Pseudomonas. Okay, any questions? So then the last table, again, is pretty similar. What do you see as the big difference between severe CAP and non-severe inpatient CAP? So what is different with the standard regimen here?
What is different between what table?
The one that we just looked at.
Yeah. Sertraline.
What was that?
Sertraline.
Ceftaroline. So that is the same.
The MRSA,
It's still the same 2 drugs for MRSA.
Vancomycin and linezolid.
Now this is the same. This box is the same for both of those. So what's different here is that, remember, here we could use a respiratory fluoroquinolone by itself, okay? But here in severe or ICU patients, can we use a respiratory fluoroquinolone by itself?
No.
No. Everything has sort of 2 agents. So every regimen has at least 2 drugs for severe patients. So even if you give levofloxacin or moxifloxacin, it's still suggested that you combine it with a beta-lactam. Okay. So that's the main difference for the ICU patients. Okay, and most patients who are in the ICU, or not most, I guess, but there are some additional risk factors. So we talked about especially if they have received IV antibiotics within the past 90 days, you want to add both. You want to make sure that you're covering for both MRSA and Pseudomonas. Okay, so in addition to having a history of MRSA pneumonia or a history of Pseudomonas pneumonia, also if they've had IV antibiotics within the past 90 days, you want to use these agents. Does that make sense? Because they are at risk for drug resistance and, just different bugs. Okay. CAP therapy is usually at least 5 days, okay? But the patient also has to show signs of improving and clinical stability. So, you want them to have normal vital signs, and just make sure they're overall improving. All right, so that's CAP.
So for CAP here, the therapy here, you said it measures at least 1 normal size As it can be heart rate, blood pressure, anyone, just one, right?
Sorry, say that again.
So you said duration of CAP therapy, right? You said it measures at least normal size. So it can be heart rate, blood pressure, temperature, any of that.
Well, you would want these to normalize. You would want all the vital signs to normalize. Okay. Okay, so HAP and VAP. The difference here is that when you acquire the bug in the hospital, the bugs that live in hospitals are very different than the bugs that live in the environment outside or in the community. So these are the most common pathogens that cause hospital-acquired pneumonia. And so these are going to be the bugs that our empiric regimens need to treat. And so this is the treatment table here for patients with hospital-acquired pneumonia. And so the breakdown is a little bit different than in the communities, from in community-acquired pneumonia. And these are sort of the three classifications. So not at high risk of mortality and no risk of MRSA. Not at high mortality, but has a risk of MRSA. Or at high risk of mortality or received IV antibiotics in the past 90 days. So depending on, where they fall, then you choose from the antibiotics that are in the column below. Okay, so up here, all of these antibiotics in the darker blue boxes, all of these are drugs that treat Pseudomonas, because Pseudomonas was the number one cause of hospital-acquired pneumonia. So all of these treat Pseudomonas.
These are the ones in bold.
Not all the ones in bold, all the ones in these three boxes.
Okay.
The bolds are just the ones that I'm holding you responsible for. Okay. Same as what we've been seeing. If the patient has risk factors for MRSA, then you need to add vancomycin or linezolid. These are our two antibiotics that are recommended for, MRSA pneumonia or possible MRSA pneumonia. And then for the sickest patients who are at very high risk of mortality or at very high risk of drug resistance, then you actually do double coverage. You pick two drugs that cover Pseudomonas, bless you, trying to avoid 2 beta-lactams if you can. So a lot of these are beta-lactams. So you wouldn't want to put cefepime and meropenem together because they're both beta-lactams, but you would try to pick, cefepime and something else, like a fluoroquinolone or an aminoglycoside or something like that. Okay. So it's mostly, the main thing is to understand this treatment algorithm, not specifically to, memorize it per se, but to understand it and be able to apply it. And that's the main, kind of the main gist of HAP. The treatment duration for HAP is usually 7 days, but it can sometimes go longer. Okay. All right, questions about this topic? Okay. All right, let me switch over. Let's talk about STIs. Okay. All right. You guys can see the new lecture, right? STDs. Okay. So there are a handful of different STDs that we covered. We sort of lumped them into three categories based on how they usually present. Like, so meaning like how they usually, what signs and symptoms they usually cause. And so the categories for the STDs are infections that usually cause urethritis or cervicitis, infections that usually cause vaginal discharge, or infections that usually cause genital or anal type of ulcers or lesions. Okay. So I think we talked about 2 or 3 from each of those categories. Urethritis and cervicitis, the 2 ones that we focused on were chlamydia and gonorrhea. So these are some of the signs and symptoms of, of that. So you can't, a patient cannot see that their urethra or their cervix is inflamed, but these are some of the signs or symptoms that they may experience. A doctor may be able to see cervicitis, for example, if they do, a pelvic exam and actually look at the cervix. But most of the testing is done, based on labs. You can't tell the difference between chlamydia or gonorrhea, or other causes of urethritis or cervicitis by just looking. You have to test, and you have to do STD testing. So the most common way that's done is through nucleic acid amplification tests. So these are, basically they can either come from the blood or they can come from like a urine swab, or a vaginal swab, and that's where it's usually from. So you take a sample of that, of that fluid, and then you send it for testing for chlamydia and gonorrhea, and the tests compare what you sent to the known genetic sequences of those pathogens. And then hopefully when you get a result, you basically just apply the guideline algorithms. So the treatment of choice for chlamydia is doxycycline. The treatment of choice for gonorrhea is intramuscular ceftriaxone. If you sometimes, a doctor could decide to treat empirically before test results came back. And when that happens, they usually treat for both because they often, a patient can be infected with both at the same time. And because you can't really tell the difference, you may treat for both, I'm sorry. In terms of, so the 3 disease states that we talked about that, typically cause changes in vaginal discharge were bacterial vaginosis, trichomoniasis, and vulvovaginal candidiasis. Yes. You're muted.
Can a patient experience this side effect but not have the disease? It can be maybe something else, or it has to be the disease. Okay.
Yeah, there are non-infectious causes of urethritis and cervicitis. But you're usually you don't want to miss if it is an infection. So sometimes providers may treat kind of treat automatically, or they can wait for the test results to come back. So it's kind of dependent on the situation. Okay, so with these three, we just kind of talked about a couple of, things about each of these. Of these three, really the only true STD is trichomoniasis. Trichomoniasis is caused by Trichomonas vaginalis. It can have a lot of associated with various morbidity and mortality. So everybody who is diagnosed with trichomonas gets treated. The drug of choice is metronidazole or Flagyl, but the regimen is different depending if the patient is male or female. They used to be the same, but women had higher treatment failure, so now they require 7 days treatment. Tinidazole is another
Is this the first line
option.
of defense for that?
Say that again?
Is that the first line of the first line of defense, metronidazole?
The drug of choice is metronidazole.
Yeah.
Yep. And an alternative is tinidazole, which is a similar drug to metronidazole. It's just usually more expensive. Bacterial vaginosis is really just like an imbalance of the natural flora where there's more anaerobic bacteria present than normal. So it does cause like a malodorous change in discharge. It can increase the patient's risk of acquiring other STDs. So that's sort of why it kind of lumps into the STD guidelines. On a wet mount or under a microscope, the main finding that is associated with bacterial vaginosis is the presence of clue cells. So this specifically correlates with BV. Treatment is only recommended for patients who have symptoms. So again, if they have that, malodorous discharge or uncomfortable discharge, then they would be treated with metronidazole as well. So the same regimen as for trichomonas, or they can get a topical topical treatment if preferred. And then lastly, vulvovaginal candidiasis. So that's a yeast infection of the vaginal area. They're usually caused by Candida albicans or other Candida species. And the important thing with patients who have VVC is to sort of classify them as uncomplicated or complicated. And that's because they can self-treat if they are uncomplicated, but they should not self-treat if they have complicated yeast infection. So anybody that has multiple recurrences or has really severe symptoms or has any kind of immunocompromising condition, they should not treat over the counter. They should not self-treat. They really should go and be seen by a healthcare provider. So in terms of uncomplicated yeast infections, there's a number of different over-the-counter antifungal agents that can be used. They come in different forms. Some are creams, some are ointments or suppositories, or even intravaginal tablets. Or you can just take a by mouth antifungal, which is usually just 1 dose of fluconazole. Patients who have complicated yeast infections, you don't really need to, you don't need to know how to manage them. They would be managed by,
Doctor.
their healthcare provider. Okay, and then lastly, were the 2 that are usually characterized by ulcers or sores or lesions. And those were herpes and syphilis. So herpes, we've talked about a couple of times throughout ID. Herpes are lifelong infections. You can't cure them. There's 2 subtypes, HSV1 and HSV2. Usually, genital infections are caused by HSV2 and are transmitted via sexual contact. What happens with herpes is that as they move, when they're present towards the skin, they can cause these little vesicular lesions that can be very uncomfortable, very painful. And then either with treatment or over time, the lesion may go away. But the virus will just kind of go a little bit deeper and hang into like the ganglia of the neurons, where they're not causing a lesion, but they're still there. And certain things can trigger them to rise back up to the skin surface and cause another outbreak. So patients with herpes sometimes they can be treated just for when they develop the rash or the lesions. Or some patients will choose to go on suppressive therapy. So meaning they take medications all the time, trying to prevent the lesions from reappearing. So that's suppressive therapy. And all of them have different dosing regimens. So, you don't have to memorize the dosing regimens or anything. You just have to understand, what the difference between an initial episode, which is the first time a patient has an outbreak, a recurrent episode, meaning a second, third, or fourth, so on, outbreak, or suppressive therapy is when there's no lesions, no visible lesions, but you're trying to prevent another outbreak from happening. And really severe, so the drugs that we use, they're all basically the same: acyclovir, famciclovir, or valacyclovir. They all work the same and are generally have the same, safety profiles. They just have different doses. For really severe disease, patients might need to be hospitalized and receive IV therapy. And the only drug that comes IV is acyclovir.
Dr.
Uh-huh.
Yeah, for the recurrent episodes, what treatments is it for?
It's the same 3. It's just that I didn't want to get too bulky. But it's the same 3 drugs: acyclovir, famciclovir, or valacyclovir. It's usually like a 5-day regimen.
Okay.
Yeah.
So are we expected to memorize them?
No. You need to know the drug, like what drugs are used, which is, the same ones throughout, for everything, but you don't need to know doses or durations or anything like that.
Okay.
But when you do, if you do, have to provide a recommendation, when you look it up, let me just pull up what it would look like on like Lexicomp so that you can see why it's important to know like what your kind of what you're using it for. So I'm share here. So I just pulled up Valcyclovir and Lexicomp, and then I went to herpes simplex mucocutaneous, because it is, our genital HSV is mucocutaneous. It's our mucous membranes. And then you'll see like different variables. So there's different recommendations if patients are immunocompetent versus immunocompromised. And then you see how there's different recommendations, whether it's treating the initial episode, treating the recurrent episode, or using it as suppressive therapy. So see how there's like 3 different regimens for each of those different situations. So you just have to know like what you need it for that patient. Does that help?
Yes.
Okay. All right, let me just switch back to the slide. Okay. And then the last one is syphilis. Syphilis is caused by a bacteria called Treponema pallidum. It's a cool little spirochete type of pathogen there. Syphilis just gets really complicated because it can cause so many different presentations in a patient depending on what stage of syphilis they have. So if you remember, basically the first stage is usually one or a couple of genital lesions. Secondary syphilis is usually rashes on different areas of the body, not single lesions, but just rashes or changes in pigmentation on different parts of the body. Tertiary is when the disease, the bug starts to get into our organs. So it causes more complex disease either on the skin or in the body. And then we also have neurosyphilis, which is when it gets into the CSF or CNS. So basically what happens is that if a patient has one form of syphilis, but it's not treated, it kind of like goes in hiding mode in the body, but then will reappear later in a different way, and it kind of represents the bacteria spreading from the genitals to all over the body. That aligns with different treatment guidelines. So you kind of have to know what stage of treatment the patient has to be able to identify what therapy they need. It's always penicillin. It's always penicillin G, but the doses or the number of doses or the type of like IM versus IV all depends on the appropriate stage.
Can we also look to the child's age, right? Like the age and weight before giving the medication, or is for neutral population?
Yeah, there's not really any these are all for adults. They would be different for pediatric patients, but it's not age or weight based.
Okay.
All right, so those are the main concepts. What you'll have to kind of do is go back and kind of look at the drug pearls that go with the different treatments. So with each of these treatment regimens, there's usually a slide or so kind of about about the key things about those antibiotics or antifungal drugs. or antiviral drugs. And that really pulls in like the exam 1 knowledge. All right, last but not least is meningitis. So I'll try to help and like kind of pick a couple of things to focus on here. Okay, so first of all, there are two terms that can describe the type of CNS infection a patient can have: meningitis or encephalitis. Meningitis is the inflammation of the meninges, which is the tissue that surrounds the CNS, whereas encephalitis actually means the brain tissue itself has been inflamed, so it's generally a little bit more severe. Meningitis will cause like some things like neck stiffness, fever, light sensitivity, things like that. Whereas encephalitis, so if our brain is actually infected, they tend to actually experience like things like confusion or altered mental status, things like that. Like I've had encephalopathic patients who like start speaking a different language. So do you see what I'm saying? Like the signs and symptoms are usually a little bit different between the two. Generally, they're treated the same, but it's just helpful to understand what the difference between those two things are. There are a lot of different bugs that can cause meningitis or encephalitis. So this slide goes through some of these. But this is just a general overview type of slides. And sometimes they can be present together as well. We do have multiple vaccines that have helped to reduce the incidence of these infections. So the meningococcal vaccine, the pneumococcal vaccine, and the Haemophilus influenza or Hib vaccine, all of these are bacteria that can cause meningitis or encephalitis. So these have been definitely reduced through vaccination. The measles are another common one that measles are a common virus that can cause encephalitis, and we do have a vaccine against that as well. So, those are good, but other bugs still circulate. So we still do see, these type of infections happening. There is something called like the classic triad. So this is especially for meningitis, but headache, fever, and neck stiffness are, when those all three of them are present together, it's very concerning for meningitis. Okay. Oops. In terms of what are the most common bugs that cause meningitis or encephalitis, the ones that we kind of most focused on, we'll kind of go through. So of the bacterial etiologies, Streptococcus pneumoniae and Neisseria meningitidis. So this is a cousin of, do you remember where you've seen this genus before? Do you remember Neisseria from somewhere else? So there was a different species of Neisseria gonorrhea, which is the causative bug of gonorrhea. So this is kind of a cousin of that, Neisseria meningitidis. And then again, some other gram-negatives, Haemophilus influenza, E. coli, Group B streptococcus. This is a common one that can be passed on from mother to baby during the birth, as the baby navigates the birthing canal. So pregnant patients are all tested and treated for Group B strep before they deliver. And then Listeria is an important gram-positive pathogen that tends to kind of be worrisome in young and older patients. To work up a patient with meningitis or encephalitis, the main thing is to know that they should undergo a lumbar puncture, which is the process of inserting a needle into the back that goes into the spinal cord and the CSF. And a little bit of sample is removed and sent for testing to try to figure out, what did get into the CNS there. And then a number of different tests can be run from that. The generic type of tests that are always done are these things here, so that it's tested for protein, it's tested for glucose, and things like that, and then usually sent for gram stain. By looking at the numbers from the CSF analysis, sometimes it can help you to figure out if it's likely a bacterial infection, viral infection, or fungal infection. So for remediation purposes, we don't need to get that detailed, but you probably will see this and revisit this in APPEs. So in terms of viruses that cause meningitis or encephalitis, most of them are not treated with antivirals. The ones that are the ones that usually cause severe disease. And the most common one is herpes simplex virus. So most patients are treated with acyclovir until this is ruled out. So this is really the main virus, but acyclovir also covers these other severe, can help to cover some of these other severe viruses as well. But we're mostly targeting HSV by giving IV acyclovir. So here's some additional information about acyclovir. All right, so the typical regimens for empiric bacterial meningitis is a third-generation cephalosporin. So this is a drug like ceftriaxone, for example, vancomycin, and then some patients get ampicillin. The cephalosporin covers most of the common pathogens that cause meningitis or encephalitis. The vancomycin is primarily added as a second drug to cover Streptococcus pneumoniae, just in case there is cephalosporin resistance. So the vancomycin isn't covering anything different. It's primarily double covering strep pneumonia. Does that make sense? So it's like an add-on drug. Bless you.
Sorry.
And then lastly, ampicillin is primarily added for patients who need, who may have listeria infection. And those are patients who are under 1 month, pregnant females, patients who are over 50 or who are immune compromised. So basically all of these variables together indicate some degree of immune compromise, whether it's age related or disease related or condition related. So ampicillin is really primarily specific to listeria, and no other drug covers that. So the cephalosporin doesn't cover listeria, vancomycin doesn't cover listeria. If a patient meets these criteria and needs to be treated for listeria, they need to have ampicillin added to their regimen. Okay. We did not really talk about TB, so you don't have to worry about TB. So the next few slides, again, just kind of go through some of that drug knowledge, which is mostly repetitive. So ceftriaxone, vancomycin, and ampicillin, as those are the key antibiotics. I wouldn't worry about any other fungal infections. Really just focus on bacterial and viral. Okay. The last thing from a drug standpoint is that some patients, in addition to their antibiotics, might be given corticosteroids. Corticosteroids, specifically dexamethasone, has been studied in patients with meningitis caused by strep pneumonia, which is pneumococcal meningitis. What it does is helps to limit some of the inflammation that can occur when antibiotics kill bacteria. So for patients that do have pneumococcal meningitis, it is recommended for them to be given dexamethasone that is started before the antibiotics for 4 days. Okay. So those are the key points from that lecture. Like I said, really don't worry about the fungal causes or anything like that. Really just focus on bacterial and viral. Questions? Okay. Let me just peek again at the plan. So all right, so tomorrow we meet again. And it'll be quick because it's only one kind of mini topic on influenza. Okay, you guys have another study day, so by Thursday we'll get you a self-check, and then hopefully wrap things up on.
Are we meeting tomorrow? Yes, right.
Yeah, 10:30 to 11:30, and I can go ahead.
Is it 10:30?
Yes. So.
Okay, I made a mistake. I thought it's 11 o'clock.
Oh, does your IAP? Hold on. Let me just make sure that you're.
The calendar doesn't show honors at all. That's why I was so confused about the time until.
Sorry, say that again, Ines.
The calendar doesn't show until today. I was able to see my calendar today. The whole of yesterday, I kept refreshing my email. I didn't see any calendar, so I was worried when are we going to meet.
Gotcha. Yeah, I just didn't send the Teams link, but I will send a link for tomorrow, 10:30 to 11:30. Yeah, so both of the IEPs have that day and time. I will go ahead and send the invite out now for those.
Okay,
Okay.
thank you.
And then, so Dr. Hong and I will both be on tomorrow.
Okay,
Okay? So we will see you then.
all right.
Okay, thank
right.
you.
Bye,
Thank you.
guys. You're welcome.